psychologist, and I focus on oral placement and feeding therapy. Camille and Robin and Christy do not give themselves enough credit for all of the blood, sweat, and tears that they put into this program. I think I've been coming here for 12 years. Is it 12? Somewhere right around there. I have to look back at all the evaluations and count. But I've been coming for about 12. Renee's been coming for 15, 18, somewhere in there. And then we just brought Jill on. She's come for, I think, the last 3 or 4 times. So it's definitely a program that is growing. It's definitely something that we are very proud of, but I know Camille and Robin and Christy are very proud of it as well, and they work very hard. It takes a lot to coordinate all of us, because none of us live here. I live in Georgia. Jill lives about 2 hours away in Jacksonville, Florida, and Renee lives in Texas. So coordinating all of us to get here, fly in, get the hotel, get chairs, coordinate all of you, it does take a lot of work. So thank you all for doing that, and thank you for having me tonight. I really appreciate it. I haven't done this presentation in so long, and Camille asked me to do it a few months ago, and I'm like, oh sure, and I pulled up my presentation, and I'm like, oh, I gotta work on this, it's a little dated. So I updated a lot of stuff, but I just kind of wanted to share with you all from my perspective as a speech pathologist what this program looks like and what we're trying to do for our children that have Down syndrome, but this also applies to children that have disabilities across the board. I know I'm speaking to you all about Down syndrome and how this program works, but know that if you talk to someone who is like, oh, my kid's not eating well, and they have a different diagnosis, it applies to them as well. So this goes across the board. I'll never forget when I first realized that I wanted to go into this niche of speech pathology. I called my professor, my graduate professor, and it was right after I got out of school. I was in the school district. And I said, I'm working with all these kids. I've been working with them for like 6 months, and they're all talking a lot more, but I can't understand them. Like, it's getting worse. And she's like, yes, are you addressing the muscles? And I said, we didn't talk about that in grad school. She said, yes, we did in the adult classes. I'm like, well, why did we talk about it in adult classes and not in our kid classes? And she said, well, it's the same muscles. I'm like, oh, yeah, I guess they are. And that's still kind of the emphasis in graduate school now. They're still not teaching the younger speech pathologists that this type of therapy makes a difference. So it's always interesting to me when I get a phone call from a younger speech therapist and she's like, I don't know what I'm doing. And I'm like, yes, you do. You just need to find the confidence. You do. So I'm going to be talking to you all from a muscle standpoint on a lot of this. Who's flipping my...
I am.
Oh,
sorry.
that's okay.
We're talking.
No, you're good. You're good.
I'm doing my job.
So mouth development is very important. It starts from birth. You can keep going here. It's important to understand that what the baby's mouth development looks like. And our goal is to keep your child's mouth on track for development as much as possible. So we're going to talk about what that looks like.
Sorry, I have to get
Oh, you're good. So our goal as speech pathologists is always speech clarity. That is the end goal. We want our children to be able to communicate. That's how we get through life. That's how they're going to get through school. That's how they're going to get through jobs, is having that ability to have speech clarity and communicate with their peers, their bosses, whoever, their teachers, all of these people. Communication is key. Through that, though, we're working on different areas of the mouth. So we're working on the tongue, we're working on cheeks, lips, the jaw, the velum, and the abdomen. And I'm going to show you all how those pieces come into play with some of the exercises that we do. So a lot of people ask me how this differs from regular speech therapy, and there's many ways. But the biggest way is there's a lot of therapists that still do traditional therapy, and traditional therapy works. I'm not saying it doesn't work, but for a lot of our kiddos it doesn't work because it requires them to be able to watch me and do what I do, and can they sit and attend to a task for a long period of time. A lot of these kids, especially because we get them really young, they're not going to sit and attend to what I'm asking them to do. And a lot of times I tell them, do this with your mouth. They can't do it. Or I'm sitting in front of them saying, say ball, say ball, say ball. And they're like, I don't have any idea what you're saying. You're speaking a total different language to me. And I've got to break it down and look at all the components I'm wanting them to do to say that word. So that is what oral placement feeding therapy looks like. I'm breaking down the movements, and it's used by speech pathologists to target those specific movements that they need for speech clarity and for feeding. On top of that, it is one aspect of the therapy program that addresses the motor components and the movements that's needed. So one motor component is putting your lips together. That's a motor movement. If I do that in front of a kid and I say, put your lips together, and they look at me like, you can't do that, that tells me that there's a motor issue going on and we need to help them figure out how to put their lips together. And that tells me exactly why they can't say the word ball. Because B, you have to put your lips together to say that. So if you're not getting lip closure, you're not going to say the sound. Some common characteristics of children who are candidates for oral placement therapy, that's what OP therapy means. We look at the oral sensory issues. So you've got different types of reactions to the sensory system. You've got hyposensitivity, which tells me that you're not feeling it as much as a typical child would and process it. Or you've got hypersensitive, where you really overreact to a touch or you overreact to a sound. So I'm looking within the oral cavity to see, are you low, hyposensitive, or are you high? Or sometimes I've got really fun kids who are low on the tongue and high on the cheek. And I'm like, oh, well, this is going to be fun because you're all over the place. But that's how these kids present sometimes. So a lot of times feeding difficulties can be because of a motor issue, but it can also be because of a sensory issue. So we have to work through that. Low and high muscle tone that results in reduced skills of the muscles of all those areas we talked about, the abdomen, jaw, velum, tongue, cheek, lips. A significant gap between receptive ability and expressive, their communication. And that's usually one of the biggest things that my families come to me and they say, I know he understands me, I know she understands everything I'm saying, but she's not saying anything back. That tells me right there that you're a candidate for oral placement therapy. They're less responsive to that traditional technique. So you've tried many different therapists, you've gone, they sat in front of a therapist, the therapist has said, say ball, say ball, say ball, and they're not saying anything. That approach just isn't going to work. And then they're often seen with feeding difficulties, drooling, or gross and fine motor delays. I like to use this illustration to kind of show you all how important every piece of what I was talking about is. So I like to say the palate is the roof, the walls of your house are your cheeks, the tongue is your furniture because you can move it all around, the lips are your door, and then you cannot build a house without a foundation, and your foundation is the jaw. Yes? Oh. Your foundation is your jaw, and a lot of times that gets missed because you can't do anything without this being strong, steady, and able to move separately from all of those other moving parts. So when is a client ready for oral placement therapy? Well, most of the time it's when Camille tells me they're ready. But what we like to make sure they're medically stable. So I typically won't, have any babies who are going in for open heart surgery within the next month, or just had an open heart surgery. We want them to be medically stable. Their sensory system is ready. And when I say their sensory system is ready, I mean that they are ready to sit and let somebody work with them. I'm not saying they're going to love it. I've got lots that cry. But I'm saying that they are ready and it needs to be addressed. But on top of that becomes behaviors as well. If they are lashing out and they're throwing things and they're throwing temper tantrums and we can't break through those behaviors, they're not quite ready. So we need to address those behaviors first. So then, because with not being able to move past those behaviors, we're not going to make progress in oral placement therapy. When the deficit is a priority, there's so many things that all these families, all of you deal with. There's lots of different therapies. There's lots of different aspects with school. There's lots of different aspects with hearing. And there's a lot of things going on. this deficit you don't feel is priority right now, which is okay, then you're not ready. But when you do feel, hey, I can give it the time that it deserves and that I want for my child, then we'll do it and we'll work through it together. So I always say when the child and the family are ready. I'm going to show you some videos from my sweet little Lucas. And Lena and I have worked through a lot together about being ready. And I'll share a little bit about that here in just a few minutes. Here's just some before and afters of some kiddos that I've worked with over the years. And I like to point out that you can see, when I started with her, she had the big, cute little chubby cheeks, the tongue sticking out. As we worked a little bit longer, we got, more symmetrical, more symmetry there in the lips. And then as we finished the program, beautiful smile. We got rid of the cheeks that grandma wanted to pinch. And the next picture is the same. My little Justice, I'm trying to think, I bet he's probably 15 or 16 by now. You can do the next one, Camille. There he is, yeah. He's probably 15 or 16 by now. Yeah, he made great strides in the program as well. So I just like to show those before and afters because I think it's important for you to see the change, that actually physical change that takes place in the face after doing this therapy. It's also important that you all become informed. Everything you need to know about how the mouth develops from birth is a book written by Diane Barr. It's on the Talk Tools website. I bet you money it's on Amazon. And you can go buy it there, but it gives you a lot of information, and it's a good breakdown on the mouth development and why it's so important. Mouth stimulation. There's many different ways we can stimulate the mouth. Feeding, mouthing, external facial massage, and then oral massage. These are all things about their development and how we can help them. The next few slides will show you some ideas on that. Obviously, feeding is, what to do there with feeding, but mouthing, hands, and objects. You can go to the next slide, Camille. Putting objects in their mouth, appropriate objects. Putting their fingers and their toes in their mouths. They're going to do that. Those are all important stages of development in a baby's mouth. It helps facilitate sucking, biting, chewing, and exploration. They use their mouths to tell them a lot about the world. I have one kid I still work with. She's 9 years old, and I have to keep her from licking things because I'm like, that's not how we explore the jungle gym. We're going to put our hands on it, we're not going to lick it. But they use their mouth for all of that. So it's very important to know these stages of development and know when to wean them off of this. Hand to mouth, 2 to 3 months old. Generalized mouthing, licking, sucking hands, objects, 4 to 5 months old. And then discriminative mouthing, meaning just a greater variety of movements around 5 to 6 months old. All very proper stages. Face massage is also very important. It stimulates blood flow in the cheeks and the muscles, provides some positive tactile experiences. And we like to use a variety of different textures. Hands, lotions, washcloths, sponges, warm, cold, all those different kinds of experiences to help them start to regulate their sensory systems, especially if you have a child that has any sort of trauma at birth. You've got to try to help them regulate those sensory systems so they can start to process the world around them a little bit better. And then oral massage. Again, providing that positive tactile experience in the mouth. It can facilitate really good movement of the jaw, the lips, the cheeks, and the tongue. And it gets babies ready for texture and food. So we start all of this day one. As soon as, if I can get that baby at 6 weeks old, I will take that baby at 6 weeks old because that's what we start. And it's always so funny when I hear the family's reaction of, wait, 6 weeks old, you don't start talking till, you're 1.5, 2. I'm like, no, there's so much more we can do. So all of that right there, the massage, the mouthing, the oral massage is all very important. And then you go into mouth play, which is really more my realm, where we start working on blowing, blowing bubbles, blowing horns, drinking from straws, all of those more sophisticated mouth movements that they will do from 12 to 24 months old. I do start teaching kiddos how to drink from a straw around 5-6 months. It helps wean them off the bottle, and it helps with that tongue development, and we're going to talk about that here in just a minute. Nose breathing is so important, and this is a newer area that speech pathologists are starting to get into. I definitely am not your resident expert on the sleep issues and the snoring and a lot of that's coming out. I'm trying to learn a little bit more, but nose breathing is so important, and I can't even tell you how many of my older clients now that we're having to go back and work on that nose breathing and teaching them how to inhale through their nose and then exhale through their mouth. The things that come naturally to us just don't come naturally to them. So nose breathing, it's all very critical for overall health. It helps the face develop and it reduces drooling. A lot of times that's why these kiddos drool. If your mouth is just open and then you have any sort of sensory system within your oral cavity, you're not feeling the drool. So it's just falling out, and then you're like, oh, why is my shirt wet? So it's kind of very cyclical and can be a bad cycle to get them into. We often refer to ENTs and allergists just to check, make sure, do we have enlarged tonsils, do we have enlarged adenoids, do we have a variety of allergies going on. I know in Florida you got allergies like we have in Georgia, and sometimes it's an allergy, so sometimes it can be some sort of allergy medication or something they can put them on. I'm not a big medication proponent, but if that's what helps to help them keep their nose clear, then it's worth it. And then doing jaw work to keep that child in a closed mouth posture. So jaw work and lip work there to keep the mouth closed. So I want to talk to you guys a few minutes about some of the myths of Down syndrome. I don't know, like I said, I've been giving this presentation for 20-something years. I don't know if these are still very prevalent within the Down syndrome community or not, if these were things you all heard before you had your babies, or if a doctor told you, oh, they're just going to have a large tongue, oh, they're just going to have... These are all myths. This open mouth, the interdental tongue posture, the large tongue, upper respiratory problems, mouth breathing, high narrow palatal vault, and conductive hear loss. Now, when I say they're myths, I don't mean they're not going to happen. I don't mean that they're not true, but this used to be a blanket statement. If you were going to have a child with Down syndrome, you were going to have these things no matter what. And the group that I've been working on with, we set out a long time ago to disprove these. And I think we've done it, looking at those before and after pictures that I showed you a minute ago. The tongue is a muscle. If it's large, it just means that you're using it incorrectly. So we've got to teach it to go retract and not go forward. So we're not bulging the tongue by making it go the wrong way. Mouth breathing, we got to work on the nose. We got to figure out what's going on there. So we've worked hard to disprove these. The high narrow palatal vault, that's a whole other thing you get into of where the tongue is sitting when the plates close there at your palate. These are all things that impact speech, but they are all things that can be worked on and addressed. So I never want any of my families to feel like, oh, we were just told they're going to have a large tongue for their whole life. No, not true. This is another great book by one of my colleagues, Lori Overland. What do we do if the mouth isn't developing normally? This is our Bible that we call it with oral placement therapy. It's a sensory motor approach to feeding. Lori was a great mentor to me when I was first getting started. She is just a genius with sensory and motor, works with all kinds of different populations. But this is a great book. We use it to help us establish the pre-feeding program, then the feeding program, and then that primary focus is always on safe, nutritive feeding and overall mouth development. So I always tell my families, when you come in to see me for an eval, and Renee and she'll do the same thing, we're going to give you exercises to do for feeding, but it's not going to be for the whole meal, because we don't want to ever take away from their nutritive stage. So if I tell you do 2 bites on each side with a certain food, do 2 bites and then feed the child in their habitual pattern. because you don't want to make the whole meal work, because then you're going to start to get pushback, and they're not going to want to eat, and we don't want to do that either. So our focus is always on nutritive feeding. So that's, I said it a little too early. I was a little bit ahead of my slide, but that's why feeding is so important to a oral motor muscle-based program is nutritional concerns, first of all. We want to make sure our babies are getting enough nutrition. And then also the muscles that are used in feeding are the exact same muscles you use in speech, just a little bit of a different way. So those two go hand in hand. So that's why we work on feeding. That's why I want those babies at 6 weeks old, because I'm going to work on all of that to prep them for the speech work that we are going to eventually do, because they're all the same muscles. So starting off when you're feeding these babies, whether it be breast or bottle, positioning is very critical for their development. You want to keep their ears above their mouth so they work against gravity. That also is very important, because a lot of times if you're holding them down flat, or if you're having trouble getting the baby to latch on, or even with the bottle, and you're holding them lower, that milk, if they're not swallowing it appropriately, is getting stuck in the ear canals, and that's what's causing continuous ear infections. So we always tell our families to hold them up, ears above the mouth, and then they're also then having to work against gravity, so they're having to work a little bit harder too. I always say seek help from a trained professional if you need it. These are blanket statements. It's not meant to work for every child, especially if your child has heart issues. We don't want them working too hard during feeding, because we don't want them burning all those calories that they're going into. We want them healthy for their surgeries if they have to have one. But then you can refer to the Oral Motor Myths of Down Syndrome by Sarah Rosenfeld Johnson as well. So the tongue, we do a lot of focus on the tongue, and mostly because of what we talked about. Our kiddos with Down syndrome get into this pattern of the tongue is going to go forward for every little thing we do. Every time we take a drink, every time we take a bite of food, it's going to go forward. Well, our straw program that we work on 8 different regions of the tongue. And so this is kind of how this is, evened out here with the numbers. So the first straw, we're working on the very back of the tongue. And then number 2, we're working on that number 2 and number 1 area. Number 3, then we're working on 3 in that area. And as you can kind of see, then we're eventually working on the whole tongue. All those tongue movements are needed for a specific sound in speech, or a syllable in speech. So your tongue has to be able to do there's some sounds where your tongue has to do 3 different things at once. And again, we don't think about it because it just kind of happens naturally for us. But for our kiddos with these diagnoses, it is very difficult. So making that tongue do those movements, it's tricky. So that's why the straw program is very effective for those movements with the tongue. So we teach the honey bear with the straw. I guess I left it up there in my bag, but there's a video of it. We teach honey bear with the straw. That's how I teach my kiddos to drink from a straw. A lot of my families come in and say, oh, no, we're drinking from a straw. And I say, oh, really? Show me. No, they're not. They're putting this much of the straw in their mouth, and it's on their tongue, and they're using their tongue to suckle the liquid up. That is not drinking from a straw. Drinking from a straw is a true suck where you're only using your lips, and the straw is not going past the teeth. So it stops here and sucks. Now, before any of you raise your hand and say, well, but I put my straw on my tongue, well, you have an intact muscle system. Our kiddos that do not have an intact muscle system, they shouldn't be doing that. So I've got a friend that argues with me all the time, that's how I drink from a straw. And I'm like, well, we'll talk about your issues later. But that's always my argument, is we have an intact muscle system. So, and then we go up the hierarchy. There's 8 straws in the hierarchy. And we have a certain amount of liquid you have to drink from it in order to move to the next one. I'm very particular. I take it very slow with my kids. They get frustrated with me because they're ready to move on. But I always go for efficiency and effectiveness. So I think next I have a little video of Milo, and I'm teaching her how to drink from the honey bear. Okay, go. You go. Suck. Suck, suck, suck. Come on, Milo. Come on. That's me. So there, I'm putting the straw, I've got it pulled out pretty far, I'm putting it on her tongue, I'm squeezing the honey bear, and then when the liquid hits her tongue, she starts to round her lips and do that suck, and then she gets a little bit. And then she's like, what? And then we start to lessen how much of the straw we're putting on her tongue. So we start with that suckle, and then we start to move it back to where she's only using her lips. And she got it pretty quick. It's amazing to watch them when you start teaching them that, how quickly they can get it. So it is fun when they get that. There you go. You go. Suck. Suck. Yes. Come on, Mila. Come on. Spoon feeding. We work a lot with spoon feeding because if you're using a spoon, they need to be putting their lips on the spoon to retrieve the food. I know a lot of us, myself included as a parent, I put the spoon in, raised it up, scraped it off the teeth, and let's just go. Let's get dinner over with. What I'm looking for is you're putting that spoon between their lips. The child is intentionally putting their lips on the spoon and retrieving the food. So I'm working on, again, lip closure that I need. There's different positions we do with the spoon, but I'm waiting for them to remove that food. And again, that's something we would work through if you came to see me. I'm not going to have you do the whole meal that way, but we are going to work towards you having the meal being that whole way with the child participating willingly. Cup drinking is another very important one that we work on, in addition to straw drinking, because we want them to be out in the real world. We want them to be at school. We want them to be able to drink from a cup, so we work on that lip closure on the cup, teaching them to be able to hold the cup themselves. Independence is very important, and those movements that are involved, and we work through a variety of different cups, and we find what works best for you all. Solids. Solids are always tricky. A lot of times, sometimes I get kids, they're 5, 6, 7, 8, and mom's like, oh, they're eating everything. And I'm like, okay, great, bring the food and let me see. And I'm like, oh, when I watch them eat a chicken nugget, I just about die because it's like 2 bites and then they swallow the whole thing. And I'm like, oh my word. No. So we need to go back and work on that munch chew and teaching that child how to move the jaw up and down, chew the food effectively, and then swallow it. And sometimes that starts with placement, but I never ever use food to teach feeding. I use these tools because if a child is going to choke, I don't want to be putting food in their mouth that they're going to choke on. So I'm teaching the movements. I'm using my glove finger first, rubbing back and forth on the molars where the molars will eventually come in. I'm not putting a glove finger in if they have teeth. Then I switch to an impident. I do not want to get bit. I've gotten bit, it hurts. Then I switch to an impident. I add some texture. And I love the impident too because I'll stick it in ice water and get it really cold. Or sometimes you can add a little bit of the liquid on it to give it a taste. Then I move on to my Arcs Pro, and then from there I'm trying to get them to get that munch chew pattern. When I'm pushing on the jaw and rubbing, I'm trying to stimulate that reflex of munch chew, up and down, up and down, up and down. And then we switch to the Talk Tools, the bite tubes. This is the only exercise we use at Talk Tools that works on strengthening. So they have to be able to bite these and compress them 10 times on each side. What I was going to say about the solids when they come in to eat, and they tell me, oh no, they eat everything, and then I put this in their mouth and they can only compress it 2 times, that tells me they shouldn't be eating everything. I want them to be able to compress it 5 times on each side before I start introducing solids. And when I say solids, I don't mean like meltable solids like puffs and applesauce and those kinds of, I mean things you have to chew. Mostly from a protective standpoint from the airway, but also to help them with sensory and processing things that are within their oral cavity. If they're eating that fast, they have no idea how much food they have in their mouth, and that just sets them up for a choking incident. And that is the last thing we want to happen because it scares you, it scares them. If they're with me, it scares me. So teaching them safe, effective feeding like that and working on those movements that are needed with the jaw are very important. A little game I like like to play with my kids is therapy plate and then their plate. So a lot of times when feeding's hard, they don't want to work on it. They just want to eat their food how they want to eat their food. And they don't want you telling them what to do with their food. So we start with a little plate, that's your therapy plate, and you have 2 bites on it. You do this, then you can have your food to eat however you want. I don't even care what you do with it. You have your food to eat however you want. Of course, it has to be safe, but I'm saying you're not going to make the whole meal work. I will teach you how to put the cube back on the back molar when we're ready for food, so that they know, oh, something's there, just like it was with the bite tooth that I showed you. Something's there, I have to start chewing. And we take that tongue out of play. That's going to help a lot with that you see, because that's them moving the food back to chew it. So you're just going to start by putting it on the molar where it needs to go initially. Because you and I take a bite and we use our tongue and we sweep the food over to the molar. Well, the only way they know how to sweep that is to do that. So we're taking the tongue out of play, just putting it on the molar, and then initially we start working on that tongue movement to get it going. Level hierarchy. Why is blowing so important? It is a lot of fun, but it's not just for fun. Breath control is so extremely important for speech. Speech is shaped air. If a child cannot blow a horn or blow a bubble, they're going to have a really hard time producing speech. Even if I'm sitting in front of a child and I'm saying, say ah, trying to get them to say something, they don't have enough air to be able to say those sounds. We're never going to get enough air to be able to say words, phrases, sentences. I've got a client right now, fantastic young man. He swears that this has been the best thing he's ever done for his breath control. He's worked so hard, but it's been amazing. He was in band and everything through high school, and it has been so amazing to watch him change over the last 2 years. It's been 2, right? 2 years. I could understand him pretty well. It was not 100%, but it was pretty well. But he was having issues with feeding at the age of 29, and he was frustrated by it. And so they came to see me, and we started working on some of these exercises. I adapted some of them so he didn't feel like he was a little baby. And it's been a lot of fun, him telling me what ones he's willing to do and which ones he's not willing to do. But he has made so much progress, and now we get on our teletherapies, because I do teletherapy with families once a month. We get on Zoom, and I can understand almost everything he's saying. It's been amazing to watch, and he realizes it, but he tells everybody it's because of breath control. And it's right, he's right. He's had to work on that abdomen. He's now blowing bubbles 3 feet, sometimes 3.5 feet. He can get them all the way across the room, but it's because he's learned how to take that breath in, breathe through his nose, and blow out of his mouth, and that's what speech is. You and I take a breath in, and we speak on exhalation, and that's what he's learned to do, and it's been a game changer for him. Okay, don't start the video yet. This is my little Lucas. This is Lena's little boy. We have worked through some major trials with this program, and Lena has stuck with it. I'm so proud of her. She works really hard with him, but we had to adapt how we did some things. I am very regimented. I like them to sit in a chair and do therapy, and Lucas was not going to do it. So we do it in the bathtub. And Mom videos it and sends it to me, and it has worked really good. I don't know what we're going to do when he outgrows that tub. We're going to have to come up with something new.
Something else. Bigger tub.
Yeah, a bigger tub. But he has done so well with some of the ways we've adapted some of this. So I wanted to show you guys this video, because when Lucas first started, the first thing he did the minute we brought the tools out was just shake his head no and start crying. Like no one was touching his mouth. And I want you guys to see what Lena has done with him.
Good job. Look at all those bubbles. And good job. Cut.
So he is blowing bubbles now like a champ. And then I think the next one,
Good.
yeah, here's his horn. me that video. She's like, you're not going to believe it. And I watched it and I'm like, you're right, I don't believe it. Because it used to be chasing him all around the house and him crying and Lena crying. Yes, I wasn't going to bring it up, but we did have a few therapy sessions.
The second.
Yeah, that's the one we just did. Yeah, you can go to the next slide. Thank you. So speech should be fun. Oral placement should be fun. Feeding should be fun. And if we're working at the right level with our clients, it is fun. And that's what I count on my families to tell me. You know, when you all come to see me, I make it look really easy. I've been doing this for a long time. And then you get them home and you're like, wait a second, what? They won't do that for me. Well, then we back up and we adapt. And you meet your child where they are. And we figure it out. And that's what Lena and I did. And Julie and I have done that. And Sarah and I have done that. I mean, we've gone through, and there's times where we're like, okay, we're making progress here, we're not making progress there. You have to meet the child where they are. Because the main thing is that they feel successful. Because if they don't feel successful, they're not going to keep doing it. Speech work. Children learn it in different ways. They hear it, they see it, and they feel it. Our whole program is about feeling it. I'm using these tools to teach them movements so they feel those movements in their mouth, and then we're going to go to, oh, did you see what I did? Now watch what I did, and do it with me, and say the sounds, and then they can do it. We use a lot of variety of tools to get these sounds. Here, Renee's using her apraxia shapes. There, I'm using an apraxia tube. And getting their mouth in position to say that sound. I'm just putting the tube in, and then they're doing the rest of the work, but I'm giving them the position that they need. And then we start to fade those tools out. I love that it says start early, and I agree with it, but I can tell you right now, it's never too late to start. So take that statement with a grain of salt. I say start early because I love to get the babies, but I also love to get the 30-year-olds because they are a lot of fun. And they keep me on my toes. Sam keeps me on my toes. Julie always writes me, thank you so much, we've learned so much from you. I'm like, oh no, I learned a lot from Sam too. So here's how oral placement therapy addresses speech development. If you all want to take a picture of that so you know, hey, why are we working on lip closure? Why are we working on tongue retraction? Lip rounding and spreading for vowels. Dissociation, and then grading. And all dissociation means is you're able to move one body part without moving another body part. So I'm able to lift my arm without having to use something else. So they're able to use their mouth in different ways. Their lip can move separately from their tongue. Their jaw can stay stable. And then grading means that it's a smaller, finite movement. And I use grading a lot as an example when they're drinking, because a lot of kids will take it and then they go to lift it up to their mouth and they don't have the grading in the wrist or the elbow, and then everything spills on them. Well, you've got to have grading in your lips, you've got to have grading in your jaw, and grading in your tongue to be able to produce a lot of these sounds and then be able to speak in phrases or sentences. I lost my clicker. My clicker lady.
I feel like we do.
No, I'm probably talking too fast too. All right, here's my little Sam in action. I shouldn't say little, he's not little. He would kill me if he was here. Here's my Sam in action. I begged him to do a video and he wasn't there yet, but we have taught Sam to do his exercises by himself. So he agreed to take pictures for me so that you all could see placement of certain exercises that he does. But his movements and his mouth on these exercises are absolutely perfect. And he works really hard. He looks in the mirror, he does the pictures, he asks me when he's doing it, is this right? Is this what you want? Yes, it's what I want. He follows instructions beautiful. So that's why I say it's never too late to start, because there's some benefits to working with adults because I don't really have any behaviors. And he asks my opinion and I love it. But Sam has worked really hard, and that's the other thing too with this. You never really get done with an oral placement therapy program. It's kind of like exercise, and it is all based on exercise physiology. If you stop exercising, you're gonna lose some. And so you're gonna have to come back and revisit. But we can teach you ways to generalize it into your everyday so that your child is still working on it and you're not having to sit down with them and do all these exercises every day. And we do work on that so that they have some independence with that as well. Here's some other examples of jaw work, lip work, cheek work, tongue work, and then the abdominal grooving. We're working on the diaphragm there. This is my little Cora. This is one of our higher level activities, but I wanted you all to see it because, well, first, it's just a really cute video. I've been working with her for about 3 years now, and she has made leaps and bounds in the program as well, and is now on this really difficult exercise, but I wanted you all to see this.
Close your mouth. There you go. Okay. Close your mouth.
That's Dad.
Go. Oh.
So that's a button, and she has to put the button in front of her teeth, close her lips around it, and then Dad has dental floss or string, and he's pulling it, so he's giving resistance, and she has to hold it in her mouth. And she works really hard at it, but I couldn't pass up the giggle there, because it's so precious, because she's not always that happy. Because it's hard work. And I think a lot of times we need to realize that it's hard work for them, and give them a little bit of break. I wanted to show you all this video also. This is Cora. We have graduated. I start with a word flip program where it's just single words and they have to say the words. And then this book is called Phrase Flips. And so now we're working at the phrase level with her. So I wanted you guys to hear her speech.
Pink pen. Pink pen. Good. Pig. Pig pen. No, hang on. Pup. Purse pup. You got it. Okay, keep going. Pine. Pointy pine. Bug. Big bug. Bubble bath. Bubble bath. You got it. Bed. Bunk beds. Bunk beds. Bush. Berry bush. Bush. Mad monkey. No, mad. Come on. Mad monkey. You got it.
So that's just always a good video to close out and show you all that. All the hard work pays off. They do get there. Every child looks different. Every child looks different. No one's program is the same. There is no, you're 2, so you should be on straw number 4. That's just, every child is different. So it's really hard when people ask me, well, where should I start? Well, what should I do first? And I'm like, well, I kind of have to see your kid first because it's tricky. But I know that there's some things that you all can take away from here. If you have any questions, I'll be around. I'm happy to talk to any of you and answer any questions. And if you feel like it's something that your child and your family would benefit from, I'm sure Camille would help you set up. We'll be back. think end of February is the day we're working on right now. I'll have those dates solidified before I leave this time. So,